fast because of this very strong interaction between us, because also we were at that time a small community of people involved in HIV/AIDS all over the world, and it was a lot of solidarity to work really strongly, efficiently together. As a result, therapy was developed. And in 1996, we had the first data showing that the combination of 3 antiretroviral drugs was very efficient to treat the patient. Indeed, today, just a word on this slide. We have been very efficient in diagnosis, very efficient in therapy, not so efficient, we must confess, in prevention and in vaccine development. I will come back on that point later. Regarding therapy, today we know clearly that antiretroviral treatment, the highly active antiretroviral treatment called ART, that associates 3 drugs together, is reducing the mortality of more than 85% in patients that are treated by this combination. Today we have 6 classes of molecules. These are molecules that inhibit the reverse transcriptase activities. We have 2 classes, nucleoside inhibitor and non-nucleoside inhibitor. We have protease inhibitor, one other enzyme of the virus, fusion inhibitor, the inhibitors that inhibit the fusion between the viral membrane and the cellular membrane, integrase inhibitor, very efficient drug. And lastly, we have a drug that can block the recognition of the virus, by the virus, of a co-receptor of the virus on the cell surface, the CCR5 receptor. We have overall a panel of about 30 drugs for heart today. This is really a wonderful issue. Today we can say that in the rich country, in Europe, United States, we are not speaking anymore about AIDS. We are speaking about people living with HIV or not. This is wonderful for the rich country. But the story also shows how much inequities we have in health. Indeed, after the disease was recognized in the States, the virus in France, I was lucky enough, I say lucky enough, because that really changed the course of my scientific career, I think, to replace Professor Montagnier for a WHO meeting in Central African Republic in Bangui. That was in 1985. For the definition of AIDS in Africa based on only clinical criteria. Indeed, I discovered the situation in this very poor country of Africa, and it's how I decided to start to be involved again together with others. Together with others to start training and to improve education about viral infection, about those diseases, and the first course was in Central Africa in 1987. We followed by courses in Vietnam in 1988. In 1988 in Hanoi, before the first case of infection was recognized in Vietnam. Indeed, it was recognized 3 years after, in 1991. So that was a start for training, strengthening capacity, improving human resources also in those countries since the very early years of HIV. And that reminds me, as a scientist working at the Pasteur Institute, what Louis Pasteur, had already in mind himself. He had the vision. He had really the vision that we should still have today, saying that science has no barrier, no frontier, because knowledge is belonging to humanity and is really the flame that enlighten the world. I think we should keep in mind the Pasteur vision, even today. When we made progress in science, we have success in science, but very often it's much more complicated to translate the progress in science into large-scale public health action. There are several steps and issues that should be considered. Very often we have to validate the scientific progress and the scientific evidence in the site, locally, to have credibility for the leaders that will make the decision. We had to set up also on-site surveillance epidemiological study. We had to establish well-characterized cohort directly on-site. We had to make operational and clinical research directly on the site, as well as socio-economical research to provide scientific evidence for the policy makers. So we have a need for a strong interface between scientists, health workers, and the policy makers, the providers of drugs or the provider of kits. We have to make very strong interaction with the patients, with the civil society themselves, if we want to be successful. We had to participate to awareness, diffusion, advocacy, in order to be part and give advice for national program guidelines and decisions, and to help for coordination of activities directly on site. Research, for me, should be a permanent component of all the activities. Indeed, if you look carefully in the countries that are doing quite well in HIV/AIDS, like yours in Thailand, indeed, all the components were there. Research started in the country, directly on the country, and you have today very good operational and clinical research, let's say, here in Thailand. And you have action, intervention for prevention, intervention for access to care and treatment for the patient, and monitoring of the patient. This has been possible here in Thailand, like in any other country, because of strengthening local infrastructure, making capacity building, training of health workers, improving the organization of the health system. Even in my country, in France, it was like that at the beginning. We had also to improve our health system. So we had three really compulsory synergy components. It's the synergy, which is also a key issue in that story, as it is for most of the things that are important for human beings. And we have examples. We have examples of successes and failure in different countries. Of course, I'm showing Thailand with the early success of Thailand in terms of prevention because of the national program, showing very rapidly that at the end of 2008, the prevalence of infection strongly decreased in Thailand because of the decisions that were taken. We had other countries like Uganda that was quite successful as well in terms of education, prevention programs and counseling programs. And you have the case of KwaZulu-Natal in South Africa, where you can see that all over the year it has been an increase of the prevalence of infection up to almost 40% of the population there. The differences in the three countries here was political willingness, really. Another example in the region, the one I know quite well, is the example of Cambodia. Cambodia, it was really a mobilization of, and a response of the national authorities in Cambodia with the support of international organization, institution. We started as soon as we could after a training program, several of us to set up research directly in the country, in Cambodia, in order to provide information. We had evidence through further MSF program, Médecins Sans Frontières program in Cambodia, that the treatment could be very efficient in Cambodian patients with more than 90% effectiveness. And as a result, today, I must say that first of all, without any intervention, we will have seen the curve growing up in Cambodia, and the reality is today that we have less than 0.2% of prevalence of infection in Cambodia. And I can say that today, about 35,000 patients are on heart in Cambodia, the number of patients that need to be treated, based on 200 CD4 cells. This is also another example that showing that antiretroviral treatment is, the coverage by antiretroviral treatment is starting to show consequences on mortality in some countries in Southern Africa. You can see here that with antiretroviral treatment, there is an increase of the rate of decrease of mortality compared to the absence of antiretroviral treatment. Today, the progress in access to antiretroviral treatment in low-income countries is significant. It's significant because of the international efforts through the Global Fund, through the Clinton Foundation, through the Bush program, and so on. You can see on this slide that we have multiplied by 10 the number of patients that are on heart in low-income country between 2003 and the end of 2008. It's wonderful. Today we can say that about 40% that need to be treated by ARV are on ARV. Is not sufficient. Is not sufficient because you can see on the bottom of the slide that for every 2 new persons that start heart, there is 5 new cases of infection. So that means that we still have to continue our effort and to do better. To do better for the future, especially because we know today through the WHO recommendation based on scientific evidence again that starting heart at 200 CD4 cells is not enough. We should start at 350. That means that we need more effort than ever. The reason why we as scientists are there to provide evidence, as I said, to convince government leaders and health authorities to take the decision for the benefit of the public health. And it's our role, it's our responsibility, of course, to provide the scientific evidence, but also to make pressure on the government leader and health authority, to make pressure with others, with our colleagues, the activists. And we know, and HIV/AIDS has been, I think, one of the best examples, how much representative of patient can make